Dos, uno. Hello, everyone. Hope you're doing okay. My name is Gaston Tesada. I'm the director here at Oasis of Hope Hospital. We're going to get started in a few minutes. Just going to give more people the chance to sign in. We have a big group, which is amazing. Why don't you take a moment and let us know where you're joining us from? It'd be amazing to know how worldwide our audience is.
Yeah.
And we'll get started in about 30 seconds. Thank you so much. Okay, so we got Janice from California. Hey, Janice, how are you doing? Emil from California also. And we got Anne from Prescott, Arizona. Andrea from Virginia. Katie from Rockledge, Florida. Great to meet you. Great to have you joining us today. We really appreciate it. We got Debbie from Texas. Alyssa from Cleveland, Ohio. That's great. Cleveland rocks. We love it. We love the Browns too. We're Charger fans, so thank you so much. We have Deborah from London. We have Crystal
Wow.
from Germany. I don't know how to say. Can you pronounce that?
Where?
Seligenstadt.
Seligenstadt.
Seligenstadt. Dr. Contreras is he did a surgical oncology residence in Vienna, Austria, so he knows German very well.
But not Hochdeutsch. Viennese do not speak the best German.
High German,
Yeah,
right?
the Hochdeutsch is it's
perfect. We have wow, we have so many people joining us. We got Philbert from Canada, Jeff from Baja, Janice from Boulder, Mahi from Canada, David from Scottsdale, Jerry from Geneva, New York. Great. Danielle from Chicago, Gary from Rockledge. Thank you so much for joining us today. We're going to go ahead and get started with today's latest webinar series. And topic for today is conventional chemotherapy versus low-dose chemotherapy, IPT, Metronomic chemotherapy. Once again, my name is Gaston Tesada, the director here at Oasis. Dr. Contreras, Francisco Contreras here, our president and chairman and medical director at Oasis of Hope Hospital, distinguished oncologist and surgeon, like I said, with a residency in surgical oncology from Vienna
University of Vienna.
University of Vienna. And he's been treating patients for about 40 something years 40 something years at Oasis. We're very happy to have him here joining us today. And if you're a loved one, if you're a patient, thank you for joining us today on this very important topic. We're going to start off first with Dr. Contreras' presentation on conventional chemotherapy versus low-dose chemotherapy. While he's giving his presentation, we invite you to ask your questions. After the presentation, we're going to give a Q&A, so you can ask Dr. Contreras anything about breast cancer, lung cancer, any topic you might have about your condition also. Any theme, any questions you might have about cancer treatment at Oasis or back home, we'll be happy to answer them. You can ask those questions in the chat box or in the Q&A section also. So I'm going to pass it on to Dr. Contreras, pioneer here for alternative cancer treatments, chairman of Oasis of Hope Hospital. Lucky to have him. And I'll give him his 10-15 minutes. Thank you so much. We'll be back soon.
Well, welcome from everywhere around the world. So good afternoon, good morning. We are going to be talking about chemotherapy and the ways that it has been applied and how effective or ineffective it has been. Chemotherapy is the staple of oncology still today, but I'm happy to report to you that probably within the next decade or two, chemotherapy vastly will be a thing of the past. In the last 15 years, not one new chemotherapy has been developed or approved. And the normal or the newest form of therapies are targeted therapies. But we'll talk about chemotherapy conventional. There are several types of chemotherapies, and they work in different forms. Some of them will kill the malignant cell at a certain time in their development. Another ones are alkylating agents where they directly go and kill the cell. Other ones do through oxidative stress and so on and so forth. And so they are applied either as monotherapy or in a combination of therapies attacking different phases of the development of the cancer. They unfortunately cannot differentiate benign from malignant. So they will destroy all of the cells that are in that phase of development all over the body. And that is why chemotherapy generally is quite toxic and can provoke a number of side effects, some of which can be permanent. And so chemotherapy is applied in the most safe form possible. It's impossible really for it to be completely safe, but there are methods to give it to the patients in a way that is not so toxic. The dose is determined generally by weight of the patient or by area of the patient, by the size of the patient in square meters. In the dosages will vary, like in every drug, from a certain amount of grams per kilogram to a certain amount of grams per kilogram. And unfortunately, the School of Medicine from America is the one that generally is accepted around the world because they're the ones that have developed most of these drugs and have done most of the clinical trials, although Europe is not far behind them. And like any drug, again, it has areas of activity and dosages. So for instance, I think that you've always heard that if you have a headache, you should take 2 aspirins. And the studies will show that the most effective dosage is between 1 and 2 tablets. And generally, doctors will go for the 2 tablets. And they do the same for chemotherapy, where they usually will give you the highest dose possible. And again, that's to the detriment of the patient because the patients can have tremendous toxic effects of the chemotherapy. There are certain areas of patients or number of patients or number of tumors that respond quite well to chemotherapy. And in those cases, it's worthwhile to suffer the consequence or suffer the chemotherapy because the risk benefit is on the patient's side. For instance, lymphomas, certain types of leukemias, some types of testicular cancers where chemotherapy really shines and the cure rates are very high in lymphomas up and above 90%. But in most of the other tumors, the value of chemotherapy is very questionable. There are some studies that show that overall chemotherapy only helps about 2% of the people that receive it. But since there's nothing else, that's the therapy that is most likely to be given to a patient, in spite of the fact that in most cases is of very little value. Because it's so toxic, some researchers have come up with different ways of applying chemotherapy, and there are some alternative forms of applying chemotherapy. So, for instance, metronomic chemotherapy is where you will give 1/10 of the dosage, but constantly. That's like the metronomes that musicians use. So it's given constantly for long periods of time at a very low dose until it becomes toxic, instead of giving massive dosages to begin with. And so metronomic chemotherapy is rarely used, but it's a way of administering this. Then there are some alternatives where they say we're going to make the malignant cell more liable so that we can use less of the chemotherapy to kill the tumor. And since, for instance, most malignant tumors require a tremendous amount of sugar to provide the amount of energy that they need to grow, well, insulin is applied for these patients to starve the tissues from sugar so that the cell is going to be more liable, and much lower dosages, usually around a tenth of the dose is given. And the chemotherapy is the same chemotherapy that would be given for a specific malignancy, but at a tenth of the dose and with the use of insulin. And this is called insulin potentiated therapies. It's not used only for chemotherapy, but generally it is combined with chemotherapy. Then there is what we call low dose chemotherapy, where you go at the lowest effective range or lower than that in patients, and you potentiate that with other therapies. That's a method that we use very effectively here at the Oasis of Hope, where we use other anti-tumor measures that are natural and non-toxic, so that we make the cell more liable. And then low dosages of chemotherapy, usually half or less than half than the typical or recommended dose. And we use that very effectively. So those are some of the methods in which chemotherapy is applied. There are some chemotherapies that are applied intravenously. There are some chemotherapies that are applied intra-arterially, usually with a catheter, and you go directly to the tumor site. That's called intratumoral chemotherapy. There are chemotherapies that work with heat. So we heat up actually the solution, and we apply this hot solution usually to the abdomen for patients with peritoneal carcinomatosis. So there's many variations, and I don't think this is the place to be very specific about it. But I think that with this picture that I painted to you about chemotherapy, I'm going to be now open to questions that you may have about chemotherapy. But if you have questions about other topics, we can also talk about them. So Gaston, maybe we can start with the pre-submitted questions, or if you already have good questions live, then we can address those as well.
Yeah, so please feel free to ask your questions on the chat box or the Q&A. We'll get to it. While you think of your questions or type them in, we're going to start up with the pre-submitted question from Becky from Knoxville. And it says, to be scheduled for chemo for breast cancer, oncotype score 31, stage 1 grade 2 negative lymph nodes. Do I need Taxol or Cytoxan, and will it work with low dose?
In a case like yours, she did not mention whether it was hormone dependent or not.
She did not. I said, I'm 3 weeks post-double mastectomy. Surgeon recommended lumpectomy and radiation and chemo, and I had to argue desire for mastectomy.
So the mastectomy has been done. In early stages, the cure rate is quite high, and they want to reduce the risk of recurrence with chemo and radiation. I can tell you that in our experience, with our therapy, the 5 survival rate is much higher than with chemotherapy and radiation. So I would urge you to look at our stats. You can find the link in our website. But I can tell you that patients virgin to chemo, our 5-year survival rate in stage 4 is 75%. So in stage 1, it's much higher than that. And so if you're a triple negative, for instance, then yes, we would give low dose chemotherapy. You would be a good candidate for low dose chemo instead of full-fledged chemotherapy with very good expectancy of 5-year survival at least. Okay, All studies are done to 5 years, because usually when you survive 5 years without tumor activity, then most likely you will not die from that malignancy. It's not that people drop dead at 5 years; it's that their life expectancy can be very, very long. So in cases like yours, we use low-dose chemotherapy if you are not hormone dependent. If your tumor is hormone dependent in early stages like you, then we use hormone therapy and not chemotherapy.
Amazing. Thank you. And it was, one second, hold on. It was Becky. If you have any follow-up questions.
Also, Becky is saying that she's
Becky.
ER positive,
there
PR negative, HR negative.
Good eye, Becky.
It depends on how high the ER. If it's 90 to 100%, I would say that depending on your age and if you're still menstruating or not, then hormone therapy should be sufficient for an early case like yours.
Perfect. Becky, well, thank you so much for your question. I'm glad you were on. It was lucky that because we have like 120 pre-submitted questions. So we're going to go with one more pre-submitted question, and then we will start answering the questions live. Thank you. Please continue to type in your questions. We will get to them. We still have about 45 minutes to about 50 minutes to answer questions with Dr. Contreras. Be as specific as you can. We're here to help. Kenneth from Canada is asking, what low-dose chemo drugs would you use in my case? Stage 4 colon cancer that has metastasized to the liver. Should I have a microwave ablation done here in Canada before doing low-dose chemo, IPT, etc., or should I not have the ablation at all?
If you can convince your doctor to do cryoablation instead of microwave, it's much better. Yes, microwave ablation would be a good idea for you to have, but cryo has proven also to provoke a very positive immune response. It's almost like a vaccination against your tumor. So hopefully you can talk to your doctor to do cryoablation, and that would be a very good combination with our therapy. So before you come, cryoablation would be fine. But if it's not available and you're a good candidate for microwave ablation, that's also a good possibility for you. And the low-dose chemo that we would use is a derivative of 5-FU, which is the most common chemotherapy used for colon cancer. At a low dose, it's called capecitabine, and it's an oral chemotherapy. Very well tolerated at low dosages.
Perfect. Also, I just want to let you guys know that if you have any questions or want to speak to one of our doctors or one of our admissions coordinators, please feel free to give us a call at 888-500-4673. That's 888-500-4673, which is HOPE. Or you can call us direct at 619-690-8450. That's 619-690-8450. Or email us at info@oasisofhope.com. We can help you schedule a free consultation with one of our doctors over the phone or Zoom, or you can come down to Oasis. We'll be happy to help you. Okay, we're going to start off with the first question. The first question that was asked by Andrea Claytor. With unknown carcinoma of unknown origin, what would you use, conventional or low-dose chemo?
It would depend on how severe the metastatic process is. In about 5 to 10% of the cases, we will never find out where the primary source is. And so we know that it's cancer. We know that it has spread maybe to the liver or to the bones or to the lungs. And we don't know where the origin is. And in those cases, we do use low-dose chemo. And the most common is either capecitabine, cyclophosphamide, or the combination of them. So in cases like yours, we would definitely use low-dose chemotherapy in combination with the rest of the therapy that is very comprehensive. And again, if you would review our website, you will find an explanation of what is that we do. And also, if you read my book, here, in layman's terms, the art and science of undermining cancer, I give a very thorough explanation of our therapy here in general. Of course, then the therapies are personalized when the patient comes here, depending on their condition and depending on the type of cancer, there may be variations. But the theory of how we treat cancer is in this book, and I urge you to get it. You can get it for free. You can download the ebook directly from our website.
Yes, and we're also gonna pick 5 lucky winners and send you an email after the webinar. And if you are picked, send us your address and we'll send you a signed copy from Dr. Contreras. We love doing that. Okay, let me see. Starting up, Ursina. Oh, she's from Ursina from Basel, Switzerland. Just want to say hi. It's snowing over there heavily this morning.
Yes.
Okay. I don't know if you already answered this during your initial. What is the difference between IPT low dose chemo and what is the difference between IPT low chemo and low chemo with DMSO?
Yes. So the IPT is the insulin potentiated chemotherapy, and it's usually 10% of the dosage. With DMSO, the dosage can vary. So instead of using the insulin to make the cell more liable, you can use DMSO. DMSO is still used. We used it a lot in the past. Now we found better ways to make the cells more liable. DMSO has a number of inconveniences, and that's why we don't use it anymore. But you cannot use 10% of the dose. Usually with DMSO, you will go to maybe 30, 40, or 50% of the normal dose with DMSO.
Perfect, perfect. Okay, so Mahi is asking, which side effects of chemo are permanent, and also do you do surgery in your hospital?
The worst side effect that you can have that is permanent is damage to the bone marrow. And then a patient is going to be anemic and is going to need transfusions constantly. That is the worst. The other that is very inconvenient and very troublesome for patients is neuritis. That is very, very common. There are other side effects that will affect maybe your eyesight, that can affect your trend of thought. You know, the chemo fog is known, the term is known as chemo fog, and those can be permanent. Most of the symptoms or the side effects are temporary. They can last from weeks to months. Nausea, vomiting, diarrhea, those are usually, they can be very severe and even threaten your life, but those are usually temporary. And also the affection to the bone marrow can be temporary. So your counts are going to be dropped significantly for a few weeks or a few days sometimes, and then it will bounce back. So those are the typical temporary and the permanent side effects of chemotherapy. And yes, we have a complete surgical team here. At the moment, it's going to be difficult because we are undergoing an important remodeling of our our surgical suites, and we are doing our surgeries in a sister hospital that has opened the doors to us. But yes, we have a complete surgical team.
Yes,
at the Oasis.
Great hospital, fully certified, and we work well with them. They treat our patients very well. You see. Okay, David is asking, can chemo be fed to my GBM tumors in my brain?
Directly, no. There are some chemotherapies that will pass the brain barrier, and like Temodar, and that's the most common that is given. There are others that can do that. And so chemoradiation is usually the combination for glioblastomas, especially grade 4. And it has proven to be somewhat effective. And we do combine our protocol with that, with chemoradiation, because these tumors are very aggressive. They have a very fast rate of growth. And we need to do a combination in cases like yours.
Perfect, perfect. Mahi, you're asking, we have already passed the treatment now. What do we have to do? Why don't you, can you be a little bit more specific so we can answer that question?
Yeah, I
liver
imagine
cancer
that you
treatment,
already had the chemotherapy.
Uh-huh.
And if you had very good results, you can come here because our therapy not only will consolidate the results, if it was not a complete remission, it can enhance the results, and it will definitely repair the collateral damage that chemo and radiation can cause to your immune system, to your bone marrow, to your nervous system. And so our therapy can be a very good consolidating agent for your condition.
Yeah, for some patients that chemotherapy is the best recommendation.
Yes.
Some of them come here for preconditioning, so we can protect the immune system, enhance the immune system, and it's something that we do pretty regularly. Yeah.
And so then you are protected, and the response to chemotherapy is going to be better, and the tolerance to chemotherapy is going to be better. So that's our preconditioning protocol.
And post.
And then post, as it is in your case, then we apply the therapy again to consolidate the results, to improve the results, and to repair the collateral damage that chemotherapy or radiation provoked.
Yeah. So if you have any questions about, if you ever been through a couple rounds of chemotherapy, and you want to enhance the therapeutic effect, give us a call. Give us a call. We're happy to. But if you want to be more specific, Mahi, please continue writing your question. Okay. Anonymous, I have read that the reason cancer reoccurs is because chemotherapy does not kill the stem cell of the cancer. Is this true? And if so, what can one do to make sure the stem cell is destroyed?
That is true. I'm not completely convinced that is the main reason why tumors come back, but it is a significant factor. I believe that the main reason why the recurrence is so high after chemotherapy is because chemotherapy devastates the immune system. And so whatever cells are left behind without any opposition, and then the recurrence comes. But it is true that chemotherapy will not kill stem cells from the tumor. And the only proven therapy against stem cells from cancer to date is metformin. And that is a part of the therapy for all of our patients, because even with active tumors, if we can address and reduce the amount of tumor stem cells from the tumor, well, then the outcomes can be better and the long-term results can be better. So to date, the only thing that has proven to kill stem cells is metformin. If you have never heard of metformin, is one of the drugs that is most used in the world. It's a mild treatment for diabetes, widely used around the world, but it can be used off-label, and we have repurposed it to cancer patients because it does address the stem cells.
Many drugs are repurposed nowadays. Celebrex, metformin.
I would say that just about every drug that is used has other purposes and other uses. Why is it that this is not widely known? Is because for every purpose, you have to go through the whole FDA process.
Okay.
And since it's so costly, laboratories do not do that. And so, for instance, I'll just tell you one. Aspirin. Aspirin has been approved as an analgesic, but it's also a very effective blood thinning agent, right? And they never did the studies for that. You cannot promote it as a blood thinning agent, but since doctors know, and there's literature sufficient in the medical journals, we can prescribe it legally above board as a blood thinning agent. And many drugs have that. Yeah. And it's been proven, but they're not approved for that purpose. Yeah. And so that is what the term off-label refers to. We can prescribe it off-label because there is sufficient information, there's sufficient proof that this drug also works for that purpose. and then we can legally and above board prescribe it for those purposes.
No aspirin before surgery, right?
That's not a good idea
Not a
because
good
then the
idea.
patients can bleed more.
Got it. Okay, great question. Stephanie, I cannot find any info as to the rate of recurrence on ovarian C stage 3B after full hysterectomy and momentum removal. Is that what it is? Momentum? Is that the word?
I think at the
Where
where are you?
Right here, sorry. Momentum
Okay.
removal. Is that momentum removal if I don't do chemo? I feel like the survival rate is higher without.
You are not wrong. So it's ovarian cancer
Stage 3B.
Stage 3B. So the recurrence rate in 3B is quite high. I would say probably 60%. And we need to lower that with treatment, and usually it will be done with chemotherapy. Our survival rate in advanced cases of ovarian cancer is 3 times higher than with conventional therapy. So a therapy like ours that is non-toxic would reduce significantly the possibility of this tumor recurring. I think that the debulking surgery was a very good option for you, and a treatment like ours to consolidate those results would be much better than chemotherapy.
Great question. We had a lot of questions, and thank you so much for your questions. We'll hang tight. We'll get to you. Okay, we'll get to you. Monica is asking, stage 4 colon cancer with metastasis to peritoneum, multiple liver and lymph nodes, lungs. Any suggestions?
Yes, that's one of the most common tumors that we treat here. And depending on your condition, if you are in good condition, we can definitely treat you with very good expectancy. Our 5-year survival rate is about 36% in comparison to maybe 10 or 7% with conventional therapy. So
she's saying she's on
FOLFIRI. Well, FOLFIRI is a very, very tough chemo. So the FOLFOX is the least aggressive, FOLFIRI is in the middle, and then FOLFIRINOX. So I'm glad that they didn't give you the FOLFIRINOX, but if you're tolerating that, once you get the maximum benefit from that, because it can be beneficial, then come to us for consolidation and to improve the gains that you had with that chemotherapy.
Perfect. And Stephanie, Omentum. Yeah, I thought it wasn't the word yet. There was the one, but the ovarian stage 3B.
But I'm assuming that they removed the omentum in the surgery.
And omentum removal.
Oh, omentum, not momentum. Yes.
Omentum removal. Thank you, Stephanie. If you have any additional questions, please feel free to ask them. Okay. Anne Harrington is asking, can low dose chemo be used instead of surgery to shrink and or kill a tumor? I have been holistically healing an invasive lobular carcinoma that is estrogen positive, HER2 negative for 5 years, but it is now growing a lot.
Yes, you can be a good candidate, but I would see there are many hormone therapies available to you, and if you're hormone positive, highly positive,
estrogen positive, HER2 negative.
Yes.
Okay.
Estrogen positive, there's a good number of options for you before thinking of chemotherapy. And sometimes we do a combination, especially with fulvestrant. I don't know if you've had that before, but fulvestrant actually acts on receptors that make your tumor more liable to chemotherapy, like capecitabine. So capecitabine and fulvestrant can be combined. But in many cases, we don't need chemotherapy. In most of the cases, a good hormonal combination can be done. So if you, for the last 5 years, were taking, let's say, for the sake of discussion here, that you were taking tamoxifen, and now your tumor has found a way to grow in spite of the tamoxifen, well, then you can go to other types of hormone blocking agents quite effectively. So there are many options in your case that, and especially in combination with our therapy, that that will be very, very effective and can give you a very good outlook on long life.
Thank you, and that's a great question. We're gonna move on with Larry Mazzucchelli. I love that name. That's great. What is dosing regimen for insulin potentiated chemotherapy, and what adverse effects have you seen?
In order for it to be very effective, you need to use quite a high dose of insulin and really bring the insulin levels down. So the side effects can come mostly from the insulin if it's not used correctly. And the dosage is 10%. That's the rule of thumb. You can use 20, 30, depending on how aggressive a tumor may be. But the typical is using 1/10 of the normal recommended dosage.
Perfect. Thank you so much. We're gonna go with Richard Batke. Would you recommend trying low-dose chemo, IPT, for Hodgkin's lymphoma in a normal BMI 56-year-old?
Not really. In your case, conventional chemotherapy at conventional dosages has over 90 up to 95% cure rate, even if you are in stage 4. So how old are you?
56.
If you were my brother, that's what I would recommend to you. After you're in complete remission, then I would recommend a protocol like ours to rebuild your immune system and again repair the collateral damage that chemotherapy will do. There's no question about that. But most patients recuperate very well from the chemo and live a very long life.
Perfect. Another question from Anonymous. After going through treatment for ovarian cancer and now doing maintenance with immunotherapy, at what point does one need to be concerned about the CA-125 elevating? This last time it went up to 6 points. It went up 6 points. Is this something to be concerned about? It is almost 10 points higher than what it was at its lowest points from 14 to 23. Still within the normal range, from what I understand.
If it continues to rise, then definitely, even though it's within the normal ranges, it's concerning, and so something like our therapy would be a good idea. Ovarian cancer has a high rate of recurrence, and if your CA-125 continues to rise, then I would recommend that you would consider a therapy like ours, or consult with your oncologist to see if you would need chemotherapy or any other means. I would do first a PET-CT to determine where the tumor activity is. If it can be surgically removed, that would probably be better than chemo.
Got it. All right. A lot of questions, guys. This is amazing. I don't think we've had that many questions. We have so many questions to get to. This is great. Let me see. What is dosing for insulin? Oh, we already did that. Okay, Jeff. I have stage 3 NH lymphoma, non-Hodgkin's lymphoma. What treatments can you offer me at your clinic? And do you do inpatient treatment? Very similar to the other question.
Yes. So if you are virgin to treatment, again, the best treatment for you is conventional chemotherapy. Excellent results, usually well tolerated. You will suffer some. You probably will lose your hair, but it will come back, and your outlook on life can be very, very good. So I would suggest that you do the conventional therapy, and then if you are interested, then come to us for consolidation and repair of the immune system.
Perfect. I think you already answered this question. What are the difference in the 2 types of ablations? Which is cryo?
There are several types. Okay, so the most common one is microwave. Then there's another one called radio frequency ablation and cryo. So microwave and radio frequency, they kill the tumors with heat, and cryo is with cold. You freeze the tumor at a very, very low temperature. And the difference is that with cryo, you will have a vaccinating effect, an immune stimulating effect, more than with microwave or radio frequency ablation.
Is the type of tumor what determines what ablation you will use, or
is the size of the tumor and
size
the
of the tumor
number of tumors.
in the number of
So
tumors?
if if you have 10 or 15 tumors, it's going to be very difficult and very traumatic to try to freeze all of the tumors, let's say in the liver. So usually tumors that are 1 or 2, 5 centimeters or less are good candidates for cryoablation. More than 2, I'm not convinced that that would be the best treatment.
That's a great question, Janice. I'm learning also. Oh, Mahi, you did answer. Yeah. So Mahi she answered a question. She typed in a question before. I was HER2 negative. I was HER2 negative hormone positive. Did chemo. Now what do I do?
I think hormone therapy is what you need to do now, and you can consult with your doctors to see depending on your age and if you're menstruating or not menstruating anymore, what type of chemo, or I'm sorry, hormone therapy you are eligible for. There's a number of them. There are some targeted therapies that can be very effective in your case, and so I encourage you to discuss those with your doctor. You can call us as well, and we can discuss with you what possibilities you have.
Perfect. And Janice has another question of ablation. How do I know if you're a good candidate for ablation?
So as I mentioned, if there's not too many tumors, 1 or 2, maybe 3, and they all have to be 5 centimeters or less. The probes only will, and it's amazing how precise the cooking of the tumor is, either with heat or with cold, on the size of the sphere that is affected. And it's so the probes are up to 5 centimeters. So if the tumors are larger than that, then you're not going to cook the whole tumor.
Perfect. Diane is asking, I had a brain tumor, astrocytoma, grade 4, malignant frontal parietal right side. There is still something to see in the MRI. I mean, how would Oasis be able to help with the residue that is still showing?
If you had the surgery very recently, my advice is that you do chemoradiation first, and then come to us for consolidation. These are aggressive tumors that have a high rate of recurrence, usually very fast after the surgery, between weeks and a few months. Chemoradiation has proven to be quite effective. And again, after that, I think that the combination with ours is going to reduce even more the possibility of recurrence.
Sorry about that. Continuing on with Anonymous, are there any targeted chemotherapy for stage 4 metastasized gastric cancer, or is FOLFOX the standard?
There are no real targeted chemotherapies. And so FOLFOX is the treatment of choice in most of the cases like yours. When they did the DNA profiling or the genetic profiling of your tumor, you have certain mutations that opens the door for you to have some targeted therapies in combination with the chemotherapy, then that is a good possibility for you. So ALK, ALK, GBR, there are several mutations. So talk to your doctor to see if you have mutations that would make you eligible for targeted therapy in combination with the chemotherapy. And those can be quite good. Again, in our experience, our results are better than with conventional chemotherapy for advanced colon carcinomas. If you already started that, once you get the maximum benefit from that chemotherapy, then I would invite you to consider the possibility of coming after that therapy to the Oasis.
Well, Dr. Contreras rests a little bit. I just wanted to remind you that you can download Dr. Contreras' latest book, The Art of Undermining Cancer, on our website, www.oasisofhope.com. If you're interested in a free consultation with one of our doctors or even Dr. Contreras, please give us a call at 619-690-8450 or toll-free 888-500-4673. Thank you so much. Continuing on with the questions. Priscilla, how much success have you had on triple-negative breast cancer? We get a lot of triple-negative breast cancer.
Yes, unfortunately, they have become very, very common. And so our 5-year survival rate in patients that have received chemotherapy is around 50%, 45 to 50%. In patients virgin to treatment, it improves to about 60%. In hormone dependent, it's up to 75%.
Yeah, she's not hormone dependent.
No,
she's saying
she's triple negative.
triple, yeah. Okay.
So these are more aggressive malignancies, but still we've had very, very good results.
Okay. Yeah, we've gotten a lot of triple.
Yes, and younger.
Younger, yes. Yes. Okay. Phil Roy is asking, good evening. With head and neck, what is the best place to apply heat? Head and neck
So
cancer.
all squamous cell carcinomas of the head and neck are, in the early stages, surgery continues to be the best. Cryo or any type of ablation is very complicated in the neck because of so many vessels that you have in the neck and nerves that I do not recommend ablation in tumors of the head and neck at all, unless it's extremely superficial. But still, the jugular vein, the carotid artery, they're all very superficial, and the ablation can destroy these elements, and that can be deadly. So I do not recommend ablation for head and neck tumors.
Understood. Moving on to Jane. What is your recommended therapy for stage 1B pancreatic cancer that encapsulates splenic artery?
Well, then it's not stage 1.
Stage 1B?
Not even stage 1B. So I would say that you are out of, in early stage, in stage 1, the treatment is surgery. But when a tumor has invaded other organs, then the stage is probably 3. And surgery is not the best because surgeries for, I'm assuming that the tumor is in the tail. And if it's only in the tail, there's no lymph nodes and the invasion is only to the splenic vein, you can have surgery removing the tail and the spleen. So that could be a possibility in your case. Surgery could still be a possibility, but it's not the best therapy. It would still have to be combined with some chemotherapy. And instead of the conventional chemotherapy, which is very harsh, after the surgery, you can come to us and we can do the low-dose chemo quite effectively instead of the full-fledged chemotherapy like FOLFOX or FOLFIRI that we were mentioning in the past.
Got it. Mark is asking a very interesting question. Would low-dose chemo with insulin be effective in treating glioblastoma? I'm currently taking 330 milligrams of Temodor orally, 5 days per month. I know the effectiveness is limited, so I'm seeking better options.
I would do a complete combination with our therapy because IPT has not proven to be effective in high-grade brain malignancies. So I would not recommend IPT in your case.
Okay. Okay, Scott is asking, what are your main natural therapies that you use alongside low-dose chemotherapy?
Okay, so the number 1 is high-dose vitamin C. Number 2, high-dose B17 or laetrile, amygdalin. Then we use ozone therapy. We use hyperthermia, and a combination of nutrients that we use instead of targeted therapies, because nutrients actually can interfere with the production of certain proteins in a very specific way. So in a nutshell, that's the therapies that we use to treat our malignancies here at our hospital.
Perfect. Robert is asking, how is prostate cancer usually treated? Gleason 7.
So Gleason 7 is a little bit more aggressive than the lowest number is 6. So Gleason is a scoring method that we use to determine how aggressive a cancer is, and it actually goes from 6 to 10. 6 being very little aggressivity, and those are patients that generally do not need therapy. They can do the watch and wait process. Gleason 7, I think, requires therapy. And here at the Oasis, we use a combination of our therapies, the ones that I mentioned, with hormone-blocking agents, depending on your age. We do not use the hormone-blocking agents forever. Depending on the results, we will give the patients either a pause or a vacation, or we stop them completely once a patient is without tumor activity and has proven to be without tumor activity at least for a year. So we use hormone therapy a little bit differently than in the rest of the oncological centers. In most centers, they tell you that it has to be for life. We've had experience for many, many years where we can use it for periods of time and give vacations to the patients, sometimes without having to recur to hormone therapy. And then depending on how the PSA is doing, we might restart the hormone therapy for a while again until the levels of the PSA come back to normal.
Okay, now to Katie, neuroendocrine tumors and treatments.
So there are two families of neuroendocrine tumors. One, on the one side, we have the neuroendocrine tumors that are very low grade, and they're usually easy to treat. In most cases, surgery is more than enough without anything else if the tumor is operable. And then the other family, it doesn't go to the middle. It goes to very aggressive malignancies where we do combine the low-dose chemo with the rest of our therapies. And but especially there, our immune therapy, which is very personalized, the dendritic cell vaccine, is a big part of the therapy in aggressive neuroendocrine carcinoma. So I don't know which one you have, but at least now you have a vision of whichever one you have, what is it that we would do for you.
Katie, give us a call or send us an email. We'll be happy to discuss that your case with you. Valerie, will there be a replay of this meeting? Yes, we will post it on our Facebook page tomorrow, and it will be also on our YouTube by tomorrow afternoon. YouTube page, Oasis of Hope, 1963. All right, Norman, greetings. Oh, sorry, I'm late. You're fine, Norman. You can watch what you didn't get tomorrow. What you didn't get to view tomorrow. Debbie is asking, what if there is still cancer present after IPT chemo? Do you just keep doing it until it's gone? With advanced disease, how long would it take?
How long will it take is a very difficult question because the cancers can react very fast or not. But you can continue the IPT until the tumor goes away.
Okay. Andrea, how do you get conventional doctors to give things like low-dose chemo and high-dose vitamin C and B in the US? That is a very good question, Andrea, something that we've been battling for 60 plus years here at Oasis.
It is unfortunate that there are a few oncologists that I've heard that are quite open to this, but since they are putting their licenses in jeopardy by doing any type of alternative, most will never even
consider it.
Consider it.
Consider it. It's license things, malpractice suits and stuff like that. So some don't say anything. I mean, but it all depends on your oncologist. But
yes,
most patients, they might work with integrative wellness centers that do something similar that we do, but they can't call it cancer treatment.
Correct.
That's the only thing. Okay. Connie, if cancer has spread to the bones, can dendritic immunotherapy help as well?
Yes, very much, especially in breast cancer. That's where our best results are. But even lung cancer, which is one of the most aggressive, we've had very, very good results in patients that have bone metastases.
Perfect. And Connie, let us know more about your case if you want in the comment section, or give it, or send us an email or call us. Diana Stunkel from Germany is asking, how would you treat a malignant brain tumor
Astrocytoma grade 4. So we talked about astrocytoma. If it's possible to remove it, that's the first thing that you need to do, followed by chemoradiation. And once you obtain the best possible outcome from that, hopefully a complete remission, then I do recommend that you come because we can reduce the risk of recurrence, which is very high in high-grade astrocytomas.
Okay. David McQuinn, let me see. We want to do integrative oncology. 6 weeks of radiation and TMZ, followed by 2 rounds of maintenance. TMZ has failed. Oncologist is starting IV, so Bevas.
Yeah, it's a targeted therapy.
And Lumistine tomorrow. She says, with this, I only have a few months at best. If it works, what could you give? Could you give me better odds?
I think that the combination of the targeted therapies with ours is going to improve your odds. You never mentioned what type of tumor it was.
Let's see, maybe it's David. Can you tell us what type of tumor you have? Maybe in the comment section. Hopefully, David is.
So that if you are there and you tell me, I can be a little bit more specific because let's say pancreatic tumor is a lot more aggressive than colon cancer or breast cancer. That's where we have our best results. Even in men can have breast cancer as well. So
no, we don't. Maybe David, if you're there, tell us what type of
what is a primary
diagnosis, and we'll be happy to answer your question. Let's see. I saw Diane is asking, how could I please reach you from Germany? I would like to communicate with a doctor from Oasis of Hope. Go on our website, fill out one of our contact forms, and we will call you tomorrow morning. I know there's a time difference, but we have people here working all day. Or you can call us right now. There's at +1 619 690 8450. That's 619 690 8450. Go to our website, and somebody will be happy to help you. Thank you, Diana. Okay. A lot of questions. Let me see. Okay. Vicky, I am having reactions from the toxins due to cancer cell die-off. What would help get these toxins out of my body?
It depends on how severe the problem is. If your kidney is failing due to that, and it can happen, you need to go to a hospital. They need to flush it out with usually liquids with minerals and vitamins, sometimes just saline solution, but it needs to be flushed out with liquids. That's the most common. So check with your doctor to see where the toxicity is, why, and how they can help you to reduce that. So you're having a good response, but unfortunately too many cells are dying, and that's what's causing the problem. So hopefully you can reach a doctor that can treat you. Again, the most common treatment is just fluids in the vein, make your kidneys work more. And the purpose is to make you urinate a lot more to get rid of as many malignant cells as possible. Most of the detritus, most of the dying cells are expelled from our body through the kidneys, and that's why we need to get your kidneys going.
Milk thistle, or that's for the liver?
No, that's for the liver. Yeah.
Okay, Gina, this two-part question. I think we already spoke about triple negative metastasis to the bone. How is it treated? And also she's asking, also as a new Oasis patient, can I send patient info images for review and treatment best? Of course.
Yes.
Yes. So I'll let triple negative breast cancers that we get to metastasis to the bone. I'll let you.
Yes, we've talked quite a bit about triple negative breast cancer. That has become quite common. 10 years ago, we rarely saw triple negatives. Now we see them a lot, and usually in young patients, and our results have been very, very encouraging. So I would urge you to consider the possibility of coming to the Oasis of Hope for you. In cases like yours, we do use low-dose chemotherapy.
Great. Well, the hour flew by. It flew by. We're gonna try to answer as many questions as we can. Dr. Contreras he's been seeing patients all day, so we don't want to take too much of his time. We love him. We want him to keep doing this. So why don't we just ask about maybe 4 or 5 more questions? And unfortunately, if we didn't get to your questions, you can email us your questions, and one of our admissions doctors will get back to you. And let's see. Okay. One question, please. Okay. Could you please clarify blood transfusion? Oh, no, wait. Okay. How does someone take metformin to kill the stem cell to kill the cancer stem cells? Thank you.
The dosage is much higher than what is used normally for the treatment of diabetes. Unfortunately, in patients that do not have diabetes, metformin has very little effect on your sugar levels. It does have a high possibility of causing diarrhea and sometimes fatigue. So let us know and we can adjust the dosage. Normally, we give to our patients 800 milligrams twice a day, and that's the dosage recommended to kill the stem cells. Whereas for the treatment of diabetes type 2, it may be between 1,000 milligrams a day to 2,000. So we're on the higher dosage to treat patients to kill stem cells.
Stephanie Blackbird, I see you. We're going to answer your question right now. I have so much conflicting information about nutrition. Some swear by vegan, some swear by keto. I have seen many people suggesting carnivore. What are your thoughts?
Carnivore is not the best. There's no question that a vegan diet is a better treatment for cancer. Now, keto, but the keto diet for cancer is extremely complicated. It's not the same as the keto diet for losing weight, where that is just removing all carbohydrates. For cancer, you have to remove all of the carbohydrates and all of the protein. It's only fat, and that's a very difficult diet to do. So the diet that we've come up with, because diet is a very emotional thing, we are more lenient than just a vegan diet. And so we do provide some animal protein, limited or restricted in our diet. It's a diet that most patients can do, and it has proven to be quite effective. But the best diet for a cancer patient is vegan, low glycemic. Low glycemic is very important.
Okay, we have a question from Rosina, very specific question. I'm diagnosed with breast cancer grade 3, hormone receptive. I do not want to have radiation or chemotherapy. Would it be helpful to start with an anti-hormone therapy?
Yes.
Okay. Can cryoablation be used on a flat 2.5 centimeter lung tumor in the esophagus?
That's a very good question. I don't think so, because the wall of the esophagus is very thin, and this can provoke a hole. So the quick question is that it would be very risky, and I would talk to somebody that's a specialist in that. I've observed many, but I'm not a specialist in doing cryosurgery. But I can tell you that in the esophagus, I think it would be very complicated to do.
Great question. Okay, Angela is asking, what is best for lung adenocarcinoma? Full dose chemo, low dose chemo, or IPT? Left upper lobe removed, now negative for NSCLS and lungs, positive for mediastinal lymph nodes. Thank you.
Our best results are with low dose chemotherapy.
Okay.
Obviously, in combination with the rest of our therapies.
Okay.
So we use the low dose chemotherapy as an adjuvant to the rest of the therapy. And low dose chemotherapy on its own is of very little value.
Okay. Monica is asking, stage 4 colon cancer with metastasis to peritoneum, liver, lymph nodes, and lungs. I think we already answered this question.
Yes, yeah, you're a good candidate for a therapy if you're in good condition to travel and to come.
Yes. Can we get a recording of the webinar? Yes, you can on our YouTube page. You can watch it anytime, or on our Facebook page. Hello, doctors of Oasis of Hope. Do you practice carrot juice for cancer? What do you think about sugar and carrot juice? This question is not for today's talk, but I hope you will get the attention.
Yes, it's interesting because the basis of our diet is on the Gerson protocol, and the Gerson uses a lot of carrots, and it was not known at that time that sugar would benefit tumors, and carrot juice has almost 100% glycemic index, and we do not use it, or very, very limited.
Yeah, okay. Anonymous, have you heard of SOT therapy? That's what we were talking about
Yes.
yesterday.
Yes, we've heard. I have no experience with it. Yesterday, I was talking to somebody that wanted to know about it. I didn't have time today to look into it, but I promise that I will.
Okay, that's it's we've been getting questions on SOT therapy.
Yeah.
I think it was something that the Greek with the
Yeah,
Greek,
based
with
on the
on the
G
Greek RGCC.
RGCC,
Yes. Okay. Okay, we're gonna do 3 more questions, guys. 3 more questions, and we're not gonna get to about 30 questions that are still there. I do apologize, but our time is a little bit limited. But as I said, we can talk to you, call us, and we'll schedule a free consultation with one of our doctors. All we will need is just some basic medical records. Okay. My WBC was 18 when it was discovered, up from a normal of 10, December 8th, 23. When I changed my eating, whole grain, plant-based diet, and quit drinking and quit smoking, it went down to 14 on April 24. But in October of this year, it jumped to 21.4. Should I be concerned?
I think you do need to check with a hematologist to determine if you have any problem with your bone marrow. It's the counts are still low, but leukemias usually they start with white count elevation that has no other explanation. If there is no infection, there's no chronic infection, then we have to find out why your bone marrow is producing so many white cells.
This is a great question for the Times. What are your thoughts on ivermectin and fenbendazole to fight repurposed drugs? Yeah.
Yes, there is no question that, especially on fenbendazole, there's quite a bit of information that it can have some anti-tumor effect. And since COVID, there's also information about ivermectin having a direct anti-tumor effect. In my opinion, it's very mild, and on their own, I wouldn't suggest that an aggressive cancer be treated just with ivermectin or just with fenbendazole. But we have a number of our patients combine our therapies with fenbendazole more than with ivermectin, because the information, again, is a lot more concise, or more the other way around. It's more ample with fenbendazole. But yes, they do have mild anti-tumor activity.
Perfect. Okay, Veronica Figueroa, very specific question, so bear with me. Thank you, doctor, and your team for all you do. I have breast cancer with right breast mastectomy in 2017. No meds or chemo, lumpectomy on the same breast. On June of 23, CK2 estrogen been on letrozole. On January 24th, breast cancer metastasized to 3 areas in the bone, stage 4, still on letrozole and Exkiva. Lesions found in liver, PET scan and genetic guardian test, another mutation of
those are just genes.
Recommending put on Orserdu. What would your therapy protocol be?
Yeah, because of those mutations, that is a targeted therapy that could be good for you. But you are the typical patient where that has many treatments before, and where our therapy really shines. I think that you would be a very good candidate for our therapy, even though you were virtually cured, and more than 5 years later, this tumor came back. So that's the typical patient that comes to us, and we have very good results. So I encourage you to consider the possibility of receiving our therapy.
All right, we have Larry saying, thank you for your time. Phyllis and I will be arriving on the 1st of December. We're looking forward to seeing our Oasis family. Thank you, Larry. We'll see you in a couple of days. Okay, guys, last question. I do apologize that we couldn't get to all the questions, but please contact us. We are here for you, and we'll be doing this every 2 weeks. So stay tuned for the next webinar, which will be announced by tomorrow, and you'll get an email because you're already in in the email chain. Audrey, I have breast metastasis with nodules in my lungs that have been stable for over a year. I have been treated at Oasis. My recent treatments have been in September with having the dreaded vaccine, but my CA27 have been elevated a lot to 99.6 points. Is this normal after vaccines?
Yes, there's a process called pseudoprogression. The vaccine will cause some inflammation, and that inflammation will cause a rise of the tumor marker for a while. So just make sure that you let us know. But if you're stable and have been stable for a while, that's a very good response to therapy. And I'm sure that we will let you know when your next vaccination should be given, if need be. Okay.
Okay. Last question, and we're done. Last one. I'm just I'm just taken back by all the questions, to be honest with you. Where was I? Andrea Claytor, do you have experience with bilious lung disease and cancer that they are having a hard time locating the cancer?
Yes, as I mentioned to you, there's a number of patients where we never find the origin of the tumor, and but the pathology will let us know pretty much what type of cancer it is, not where it comes from, and from there we can definitely design a therapy specifically for you, and the vaccine is going to be very specific to the tumor, regardless of the origin.
Thank you. Well, I want to thank Dr. Contreras for his time.
Thank you all for participating and making this very amenable and I think interesting for all of us, including me. And so we'll see you in 2 weeks.
Thank you for your time. Once again, please feel free to give us a call. 5 of you will be receiving an email from us, so we can send you a signed copy of The Art of Undermining Cancer. Norma, I see your thank you, doctor, and also Lisa, thank you. Also Kimberly, thank you. Thank you also. On behalf of the Oasis of Hope family, we want to thank you for taking the time and being here today, and thank Dr. Contreras for his time. Please join us for our next webinar. If you or your loved one needed to speak to one of our doctors, please feel free to call us. We are here to help. This is a mission, this is a ministry that we have here in Tijuana, Mexico, and we are here to help. Thank you so much from Tijuana, Mexico. Thank you, world. See you next time. Bye.